to the final common pathway down in the rectum. So it's a nice review, a little bit of everything, a potpourri. And I think the talks that I've reviewed here look just great, and it's going to be up to date and kind of cutting edge GI to bring everybody up to date. It's going to be 6.5 hours of CME. You'll get that when you leave today. You won't have to have that mailed. I started off by a topic that I think we see in the office probably every day, whether you're doing primary care practice or GI or whatever it may be, and that's people that are constantly sick, nauseous, and having pain. And as the workup evolves, they have gastroparesis, which again in the past has been a frustrating disease, right, for all of us. These patients have at times a lot of other medical illnesses that they come along with. They may have some psychosocial overlay that makes it a little bit more complicated, but yet they're real. And once the diagnosis is made, we then go through the challenges of trying to treat them medically, which we're frustrated with, right? We'll see that with the medical therapy that's there. And then we're going to look at something that I've been extremely excited about for the last 2.5 years, and that's gastric pacing. And we talked about it, I think, when it was just in its infancy a couple of years ago when I was just launching it. But now I want to bring you up to date to show you where we've been and where we're going and how exciting the whole process has been. So let's take a look at what we do with a meal as we digest our breakfast here right now. Basically, the stomach is a large, hollow, muscular structure that has the ability to accommodate the meal. And it stores the meal, solid component of the meal. We're looking at solids, not liquids. The liquids tend to empty from the stomach extremely quickly, exponentially. So within 10 or 15 minutes of a liquid ingestion, it's gone. The solid component, a little bit different. It can take up to 2 hours to digest the typical average meal that we just ingested. And the stomach, again, is a grinding machine. It moves the bolus from fundus to antrum to prepyloric channel and back and forth like a washing machine. Whether you know it or not, it's doing this, and it's doing it at a cycle of 3 contractions per minute, 1 every 20 seconds. There's a wave of contractions that are beginning up in the gastric pacemaker that we all have. We have a pacer. It's in the greater curvature of our stomach, and there's a bundle of ganglion-like cells that are called the interstitial cells of Cajal. We're going to take a look at what those do. But that's what initiates the sequences to contract. And the stomach, then, its purpose is to mix a little bit of saliva and acid and other contents that it gets from the duodenum. But it does the process of what's called trituration, which is this constant grinding, masticating, if you will, in the stomach, until the particles, believe it or not, are 1 or 2 millimeters in size. And it's only then, when they're 1 to 2 millimeters, that they can adequately leave through the pylorus out into the small bowel to be further broken down and absorbed. So it's quite a process. We take it for granted, but when it goes awry, these people are extremely ill, and we see them. We see them in the office, in the emergency room, and being admitted to the hospital nonstop. It's a revolving door. And so in the past, we just didn't have a whole lot to do to interrupt these cycles. But now, again, we're very excited that we have a little something in our back pocket that can change a lot of this. So what is gastroparesis? Well, it's delayed gastric emptying in the absence of any type of mechanical obstruction. And it's important for the gastroenterologist to show you that there is no outlet obstruction. That's where the upper endoscopy has to be done as part of the workup, to show that that pylorus is functional and it's patent and it's not stenotic or diseased, and that there's nothing else in the stomach that could be contributing to the delayed emptying. Now, most of the paresis that we see, indeed, is in diabetics, but I would say that probably the population that I see is as much in what we used to call idiopathic. Idiopathic turned out to be mostly post-viral gastroparesis. These are people that get a viral illness at any time, at any part of the season. It may be CMV, it may be Epstein-Barr, it could be other enteroviruses that usually come and go through our system and they're gone, but yet some of these viruses will attack ganglia that affect gastric emptying, and then it can be weeks to months later that they start to have their symptoms of nausea and vomiting and pain. And that's what we used to call idiopathic, but they truly are a post-infectious variety of paresis. Some of the confounding syndromes that we see, I've listed here for you. I would probably say that number 3, the cannabinoids, which are just rampant, at least in Jacksonville, I think, in addition to cocaine and meth and heroin, the whole thing. The cannabinoids overuse cause an extreme nausea and vomiting because they have a direct effect on gastric emptying. So we've all seen the anorexics and the bulimics. Those are usually pretty easy to sort out. And the other people that are a little bit confounding are these so-called cyclic vomiting syndrome folks. Tend to be young ladies, but I've seen them in young males as well. They vomit periodically for 2 or 3 days at a time, and then they're quiet for 3 or 4 weeks at a time. And then all of a sudden they pick it up again. A lot of psychosocial overlay with them, but there are some thoughts that there actually may be a pathophysiologic gastric emptying disorder in some of them that makes it difficult to sort out. So, the pathophysiology of gastroparesis, what is it? Well, it's an autonomic neuropathy, just like diabetics will have in many parts of their GI tract. And the enteric nervous system is clearly involved. There are abnormalities of the ICC, that's those interstitial cells of Cajal. So these little bundle of motility fibers in the greater curvature of the stomach are diseased with this gastroparesis problem. We find that when blood glucose gets above 250, clearly gastric emptying is awry, and there are interactions metabolically that contribute to that. Now, is there psychosomatic overlay? Sure there is. It's just like inflammatory bowel disease. It doesn't cause the disease, but these people tend to almost obtain a personality disorder or trait at times because they're so sick of being sick, and they're so sick of being in ERs and being told by physicians that they're crocs and get out of my ER, get out of my hospital, when they truly have a problem. So it's tough to sort out, but it's a challenge. Now, why are 82% of gastroparesis female? Well, maybe it is progesterone. Why are they typically seen in periods of time, typically between 16 and about 45 or 50? Well, this again raises the question, is how much of this is hormonal as far as gastric motility? The mean onset of gastroparesis is around 34, although we've all seen it in 15 and 16-year-olds, and I've seen it in 65 and 70-year-olds that are truly either diabetics or idiopathics. So it's a broad spectrum. What happens in the diabetic? Well, with a lot of things. It's a shopping list of disorders that they do. They have lost a lot of their antral contractility. They lose their coordination between what the antrum and the duodenum are doing, almost like a piston, right? Driving those little 1 to 2 millimeter particles through the pylorus. They've lost their ability to propagate contractions. Many times the pylorus is in a state of spasm when the antrum is ready to propel. They're working against each other. We find many times that these stomachs in the diabetics are very large and dilated. Their proximal stomach can accommodate huge amounts of food, whereas you and I would want to have those particles moved. They don't. The vagus is clearly abnormal in diabetics. And here's our friend, the interstitial cells of Cajal, where these slow waves that are generated from that pacemaker are abnormal. And nitrous oxide, which is an interesting substance found throughout the enteric nervous system, clearly is defective in diabetics. Well, these cells of Cajal, they're interesting. They contribute to, in general, the whole ability of our GI tract to sense distension, speed of contractility, and movement. And so as a result, when they are awry, we have a variety of gastric dysrhythmias. It's almost like atrial fibrillation of the stomach. And we do this, we see this. We see tachygastria, we see bradygastria. So we see contractions, instead of being 3 per minute, we see some stomachs that go at 25 and 30 a minute, inappropriately. And we see others that are barely going at 1 per minute. So it probably is a function of what's going on in Cajal. When you see some of your patients with what look to be a bowel obstruction and they don't have something mechanical, that's called pseudo-obstruction. Probably, again, a lot to do with these interstitial ganglion cells. And the patients with irritable bowel that may have colonic inertia and chronic constipation, again, it has a background. Well, the shopping list of gastroparesis is long. The big two, of course, are diabetics and that idiopathic post-viral variety. But look at what other things can happen. Scleroderma, amyloid on occasion, CNS diseases like Parkinson's commonly will have gastroparesis. There's your cyclic vomiting syndrome we mentioned. Some of the functional GI disorders we kind of put in this category. They may also have problems with emptying from their stomach. Anybody that is in the old era of having an antrectomy and vagotomy for peptic disease, these post-vagotomy patients are noteworthy for having terrible gastroparesis, many times 15, 20, and 30 years after the surgical event. So the vagus is vital. Hypothyroidism, end-stage renal disease, these people are so miserable all the time, aren't they? They're always sick. Well, it's not just because they're uremic, it's because they have delayed gastric emptying that they're sick as well. Medications, anorexia, lupus and the autoimmune disorders, pregnancy, and I just saw a lady with pancreatic cancer last week her main finding was not so much obstructive jaundice or weight loss, it was I can't eat and then my stomach doesn't work. And she had profound gastroparesis, probably on a neurogenic relationship to her pancreatic malignancy that vicious cancer can do. Now the medications that we give on a regular basis that can contribute to paresis, the anticholinergics, any kind of narcotic, of course, a tricyclic, TPN. You've all seen people on TPN. They never have an appetite, right? They're always kind of blah. They don't want to eat because not only does the large metabolic load of the TPN solution suppress their appetite, but many times TPN by itself will delay gastric emptying, and they just don't want to eat. Calcium channel blockers, here's progesterone that we see. Alcohol in general, nicotine can affect gastric emptying. So here's a little cartoon that I thought was kind of neat, just showing the little devils and gremlins walking around here with abdominal pain. Again, surprisingly, you would think, well, why would gastroparesis have pain? But they do. They clearly, and it's not just functional, gassy, bloated, irritable bowel pain. These people, when their stomach becomes distended and not right, they have significant pain. And we have to sort that out as we admit these people through the ER. The symptoms, we've all seen it. It's nausea, it's periods of vomiting that can be violent, bloating, early satiety. Many of them, because they don't empty, they reflux avidly, right? Significant GERD. Their blood sugar levels are all over the map because they don't know what to take in. They're either taking in inappropriate calories or they don't eat at all. We'll actually see some of these patients actually gain weight having gastroparesis. You would never dream that. Well, why? If they can't eat and they're so miserable, why do they gain weight? Well, because they put milkshakes and chocolate and other garbage in their systems, carbohydrate loading, almost like a gastric bypass patient learning how to beat the bypass. They learn how to beat the gastroparesis with inappropriate foods, and they can actually gain weight instead of being profoundly cachectic. So it's an interesting dichotomy. Well, how do we diagnose this? Well, it's really not all that sophisticated. You're going to have an upper endoscopy somewhere along the line. I think it's going to give you a little more information than an upper GI series because we're going to actually look at the lining of the stomach. We can sample them for H. pylori. And we're going to look at that pylorus and the gastric outlet. We want to make sure that that's a functional, normal outlet. But the way we do the official diagnosis, and at least can work from it, is a radionuclide gastric emptying study. And those done here at Baptist, where I work, it has to be 4 hours. It has to be 4. If you're doing it out at one of the outside imaging centers, it's not unusual for them to do it in an hour and a half or 2, because they have to spin those rooms. They're not making money if they're not spinning a room. But it is vital that when you ask for it, you ask for the 4 hour, because you will miss some of the patients early on that truly have gastroparesis if you cut them off at an hour and a half. So you clearly have to give that patient every benefit of the doubt of how they empty in that first, second, third, and fourth hour. And if they have more than 10% retention at 4 hours, they have gastroparesis. And then it's up to you to find out why do they have it and how are we going to treat it. So 4 hour for sure. We used to do gastroduodenal manometry when I was at Florida. I don't think it's done much there now, and it isn't done here in town. It was occasionally helpful, but it, again, doesn't really make the diagnosis any better than an emptying study. There's a device called an EGG, or electrogastrograph, that you can actually put a device on the abdominal wall and measure gastric emptying. It's a pricey device. We don't have it here in town. It isn't used widely. I don't have a lot of belief in it or a lot of trust in the numbers that it creates. So it's just there to know that it has been used. Some people will give radiopaque markers and see how they empty from the stomach over a period of time. Again, can be done. And there's some centers that are using the so-called smart pill. It's a pill that the patient ingests, and that can show a change in pH or pressure changes or temperature changes. And as the pH changes from 2 or 3 or 4 over up to 6 or 7, you know that that pill has now left the stomach and it's in the duodenum. And it gives the examiner a rough idea of gastric emptying. But again, still not as diagnostic as a good, well-done radionuclide study. So upper endoscopy and nuclear medicine. Now, how do we manage these patients? Well, we know it's a challenge. We have to hydrate them. Many times we hydrate them at home. And I'm sure you have some people that you take care of, as I do, that have to be seen by Baptist Home Health or some agency to give them hydration at home. Electrolyte repletion is constant. Their sugars have to be controlled tightly. They really need to be 150 and below on a regular basis if they want to have some type of gastric emptying. We give them Zofran or Phenergan, Compazine suppositories, whatever it may be. Psych support is mandatory, not only from the doc holding their hand, and I hold these people's hands, believe me, to walk them through the process before they get to a pacer. You have to be there for them, and if not, they're going to use the ER as a dumping ground, right? The path of least resistance nowadays, go to the ER. And here they see a different ER physician each time, they see a different hospitalist each time, and it becomes a mess. They get admitted, they get hydrated for 3-4 days, they go out, they come back 3 weeks later with the same thing. And this is what we're trying to cut into with gastric pacing. The prokinetics I'm going to go over. At times, we have to give these people TPN support. In days past, I used to put pegs in these people and give them enteral nutrition. We would put a peg in not only for decompression of their stomach, but then I would slide a pedge, a jejunal tube, through the peg, feed them downstream, and use the peg to decompress them when I needed to. Pretty invasive, but that's the way we had to take care of some of these people in years past. That's all we had. And then, of course, surgery, in days past of gastroparesis, it was not unusual to do a total gastrectomy on some of these patients. That violent, that aggressive an approach, or a gastrojejunostomy, some way of getting that stomach to allow it to drain by gravity. But that just isn't done anymore. We just have, our medications have come along a little bit, and now with gastric pacing, we just don't have to do that, which is nice. So the prokinetics, we have a few, but we're all frustrated with what they do or don't do, right? Reglan, a dopamine antagonist, 5-HT3 antagonist. There's nothing wrong with that. But I think for some patients, Reglan has been a viable option, and it's been their saving grace. So we give it a chance. It can be given PO, it can be given sub-Q. It's usually between 10 and 20 milligrams before meals and at bedtime. And I find it very effective. I would say it's probably less than 5% of people that I've seen over the years have developed any type of dyskinetic type symptom from Reglan. But again, it has to be thought about, and that's unfortunately made us then move on to erythromycin, which is not even FDA approved. Now, erythromycin, even though it's a good antibiotic, stimulates motilin. Motilin is a hormone that's released in the stomach that stimulates gastric emptying. So erythromycin, either in pill form or in a liquid suspension, usually 200 to 250 before meals, can be used. It should be used for 3 weeks of the month and then give the patient a week off each month, so it'll be more effective and not have any other long-lasting tolerance issues.
What about azithromycin?
Azithromycin works comparably. Yeah, some people like that. In fact, in the pediatric population, that's what most of them are giving. And I think erythro is fine. I think erythro is probably good for the diabetics. I don't see it as effective for the idiopathics or for some of the others that we see, or the postvagotomies, but it's out there for us. A little hard to get recently, and it got kind of pricey for a while too, but now it's come back where it's a little bit more obtainable. Remember Cisapride, an HT4 agonist, came on. It had some QT prolongation effects problems. It was taken off the market. It hasn't appeared. It's heavily used in Europe and Asia. It's a great drug. There's no doubt about it. And domperidone, which I obtain from Canada all the time. I love domperidone. I have no relationship to the drug or its manufacturer, but I have been with it now for almost 30 years using it. Very easy to get from a 1-800 number from Canada, dirt cheap, delivered right to the patient's door. If you want a phone number, I'll give it to you. It basically is usually a 200 milligram dose before meals. Very well tolerated. It again had some QT prolongation issues, remember years and years ago, that really have not been substantiated, if you will. A baseline EKG is all that I do, and I usually repeat that every 6 months with domperidone. Very effective. For people that have gone through the Reglan erythro cycle and have failed, Dom is a nice alternative. Tegaserod was Zelnorm. Remember that drug? It kind of came and went. Bethanechol usually has too many cholinomimetic side effects. I have not used it regularly. Ghrelin is a peptide hormone that is in clinical trials right now, showing a lot of promise of having direct gastric stimulatory effects, Ghrelin. And good old Viagra. You know, Viagra does a lot of weird things. And actually it has been shown in animal models in diabetics to actually be effective in enhancing gastric emptying.
What dose?
I think it's the ones that I've seen is in usually the 5 milligram dose. Yeah, low dose, and mostly animal models though. It really hasn't been brought out to the human side in big proportion. So I wouldn't go to it as my first bet, that's for sure. Although the patient may love you for doing it, right? So we come then to gastric electrical stimulation is the better term for it than gastric pacing, better word. What does it do? And we're going to show you what this device is all about. It improves that accommodation of the stomach that we saw that was so disrupted in paresis. It definitely has direct effects on the enteric nervous system. It enhances vagal activity, thereby getting a little better gastric emptying. We believe that there may be some activation from the device to actually act centrally in some of the nausea centers, the chemotactic trigger zone up in our brain. It may affect. My former mentor, Dr. Richard McCallum, really showed this direct effect on the so-called gut-brain axis. And there actually is activity that it may even alter the thalamus, which is a major part of our brain that gives us the feeling of satiety. So a lot of broad spectrum effects that this device can do. Now, here's a stomach cartoon with the Entera. Entera is from Medtronic. Again, I have no ties to Medtronic. 2 leads are placed. This is all done laparoscopically. The surgeon I work with is Steve Hodgett at Baptist. He and I are the only ones doing it in all of Central and North Florida, which has been kind of exciting. They're placed 4 inches from the pylorus along the greater curvature. And they're placed very specifically. They're not just sutured in. There's a specific tacking type system so they just don't fall out. They don't penetrate through the wall. We've had absolutely no penetrations coming through the stomach wall, and it has been delightful to see how he can do these. And he loves doing it. It's a really fun operation for him to do all laparoscopically. The generator then is put in a little pouch on the abdominal wall. The patient hardly knows that it's there, and it's really been very, very fun to see. Most of these patients come into Baptist, have it done. Many times they're discharged the same day. So there's not even an overnight hospitalization, unless they're a diabetic that needed to be tuned up a little bit. They go home same day. And these patients, literally within 24 to 48 hours, are free of nausea. I can tell you wholeheartedly, and I'm going to share with you the 40 patients that we've done and show you the facts. This is the generator itself. Maybe when I'm done, I have a couple generators with me. I'll pass them around. You can see how thin and lightweight that they are. And then when they come back to the office, I usually see them within about 10 days of the actual implantation. And then every 2 or 3 months thereafter, I see them. And this handheld computer can then transcutaneously, over the box, over the generator box, tell me how it's functioning, how it's been set on the operating room table. I know those settings. And then I can tweak those settings however I want when I see them back in the office. So I can change the rate, the amount of voltage, the amount of time that the pulse is on and off. It's a lovely device, easy to do. The patients don't know that you're doing any programming changes. We let them know that we are making some little changes when they're not coming along the way we would like, but it's a very nice system. How does it work? It provides 2 short pulses with a frequency. Now we're up to 14 contractions per minute, right? Remember I said the normal stomach is 3 per minute? Well, we're up to 14. So it gives it quite a surge, if you will. And again, immediately these symptoms of pain and nausea are basically melted away. We've seen hospitalizations go away, ER visits. The use of prokinetics has been gone by about 70 or 80% of patients are completely off prokinetics within a couple of months of it being implanted. The medical cost that it saves is astronomical from all the visits, procedures, ERs and all that we're saving, nutrition, quality of life. The diabetics especially seem to get better fastest, and overall it says that 60 to 75% of patients with Entera prosper. Again, in our experience, it's probably 85 to 90% of patients prosper. So that's a worldwide experience that's being quoted there. Now this is a WAVE study. Again, Mike Hocking down there on the bottom right there is a surgeon at Florida, and he and I worked on WAVES together way back when. And we didn't supply all 33 patients, but this was one of the world's first studies to show that this pacer, this box, had value. And so it was a sham study, which was nice. Yes, sir?
Is this pacing all the time, only when the patient eats?
Pacing all the time, all the time. It's never turned off unless the operator chooses to turn it off for them. It's ongoing. The battery life that it has is about 7 or 8 years. And when the battery needs to be changed, the little pocket is opened, the generator's popped out, the battery put in and closed right up. Very, very easy to do. So this was some early data, and most of all it showed that the use of G-tubes was cut down dramatically, and the use of prokinetics was cut down dramatically as well. This was a national study done a few years later, again, showing that symptom scores were improving. They were not maybe as impressive as we all liked, and to tell you the truth, this gastric pacer kind of went away for a few years. You remember Mayo was doing some of it as well over here, and they lost interest in it for whatever reason. I'm not exactly sure why. And it went away. It lost a lot of fervor in the literature. And then Medtronic made some subtle changes to the generator. It came back, and that's when I embraced it 3 years ago. That's how long we've been doing it now. What is the magic? Well, it decreases the symptoms of gastroparesis. The prokinetics are basically cut off. The hospital admissions, incredible impacts across the board. Very, very impressive. Now, this slide was at 38. We're up to 40 as of last week. And it shows you the spread here of those 48. You can see 34 females, should be 14 males. Diabetics, the majority. The idiopathics come down, and then the others. There were a couple of, one post-vagotomy and one scleroderma patient that rounds out our patient population. Most of these people had been symptomatic for 6 years. A number of them had been on narcotics for chronic pain, and their main symptoms, of course, nausea and vomiting. There's their gastric emptying study. Remember we said anything 10% at 4 hours is abnormal. They were typically around 35%. So this was just a typical population of gastroparetics. And what are the outcomes, at least in those 38? Well, 80% had improvement of their GI symptoms. Pain, nausea, vomiting, early satiety, their quality of life. Their SF36s were better. 75% are off prokinetics. And again, the 2 or 3 that were on narcotics were off, which was beautiful. It seems that the diabetics seem to get a little bit better of a hit from this pacer than the idiopathics. Not exactly sure why. The nausea and vomiting seems to do a little bit better than the pain control. Not again sure why, but that's nice because there's nothing worse than living with nausea 24/7. And that's the way these people live. And most of all, they're independent from narcotics. Now, are there adverse effects? Sure there are. They're reported. We haven't really had a one, and I'm being totally honest. Of the 40 that we've done, we may have had one pouch seroma that just basically went away with time. We have not had these things. Infections of the gastric wall, no. Pain at the implant site, it's very minimal. He uses a local anesthetic that he injects at the pouch when he pulls out, and these people really feel quite good and they go home again the same day. Lead penetration, there are reports of leads actually going through the wall of the stomach and being seen on the inside of the lumen. We haven't seen that, and that really hasn't even been reported in the literature for many years. Bowel obstructions, programming difficulties don't seem to be an issue. Lead entanglement, that has all been changed by the style of the leads. Device mechanical problems. I mean, these have been reported, but we have not seen this in our experience, and we've been just absolutely thrilled. Last slide here, and I hope it shows at the very bottom. There's a lot of exciting stuff being done now to try to map the stomach, almost like mapping the atrium when the electrophysiologist wants to do his ablation study on atrial fibrillation or other tachyarrhythmias. They map out the firing sites from the different parts of the atrial appendage in the atrium. The stomach is being mapped because we're trying to find out, is that location 4 inches from the pylorus the optimal site for these leads to be placed? Could there be multiple leads at multiple locations placed? That's all being looked at. Could there be dual pulsing? One with a short pulse, one with a long pulse being looked at. There's interesting, I was just in Vegas last week for our American College of Gastro meeting. There's actually some people now doing what's called pyloromyotomy. Maybe you've heard of POEM. POEM is per-oral endoscopic myotomy. It's being done for achalasia endoscopically now, Now there are people trying to adjust that pyloric outlet by doing myotomies endoscopically. And I saw 10 cases being described by a group from Emory, I believe, that had done some significant endoscopic work. And so it's encouraging to know that something else is being looked at to try to enhance that gastric emptying. Because many people, when they place the pacer, there are certain physicians around the country that actually will have the surgeon do a pyloromyotomy at the time that he does the implantation. We don't do that, and we haven't. We've been very happy that so far so good, but that is being looked at. And at the very bottom, we're talking about some of those ghrelin analogs because they are being developed. Are we ever going to see cisapride again? I don't think so. Are we going to ever have a little bit more access to domperidone? I doubt it, because it'd have to go through the whole FDA circuit again. So we're relying on getting that from Canada and watching the patients very, very carefully. So that's where we are with gastroparesis and pacing. So I hope it kind of gives you an idea. This is being done just strictly at Baptist downtown. We're not doing it anywhere else. And for right now, it's myself and Steve Hodgett. And we're happy to see your patients, see if they're a fit, see if they've gone through medical therapy appropriately, because they really have to be given a try on Reglan, erythro, or domperidone before we actually jump in and try to be involved. So it's not a right out of the box thing. Go call Peterson and get a pacemaker if they're paretic. That's not where we are right yet. But I would love to be able to see them and kind of walk along with you as we evaluate. Yes, sir?
Do these people get off their PPIs?
Many of them do. Some, and unfortunately, and I think Ali's going to talk about just the abuse of PPIs that we all see, right? They have reflux, but their reflux improves dramatically. And I would say that the majority of them, not only are they off their prokinetics, they're off acid suppression.